Hi, everyone. Thank you so much for joining us. Really appreciate everyone's patience while we got started. My name is Einaudi Esposito. I'm the Executive Director for the Orange County Human Rights Commission, and it is my pleasure to welcome you all to our next session in our speaker series, which is a collaboration between the Commission on Human Rights of Dutchess County and the Ulster County Human Rights Commission, alongside with the Orange County Human Rights Commission. You will hear a little bit from each one of the commissioners in a couple of seconds. We are just kind of giving some time for the participants to join us. But we are very excited that you are joining us today in our conversation around health disparities in the Latino Black community and the BIPOC community. So thank you for being here. So the first thing I just want to share a little bit about the background of the series. We started this collaboration probably about a year ago now, maybe a little bit over a year ago, where we started talking about, the commissioners, just the directors from the commission saying, let's do something together in the Hudson Valley. Let's bring this really important conversation forward, all around discrimination, issues around hate, issues around racism, anti-Semitism, disability rights, homophobia, anti-immigrant sentiment. So we've really have taken charge on making sure that our community is well informed and has the resources that are available locally, because there are so many resources for all of us. So that was in 2020, and there was no reason for us to stop. So we decided to, let's keep it going. So in 2021, look out for the continuation of the speaker series. We will probably be doing one every quarter. This will be the first one in the quarter. So look out for those emails. If you're not already on our email list, please make sure you join them to get those notifications. Just some housekeeping things. Please keep yourself on mute. You can also keep your camera off so that we can highlight our panelists, especially when the presentation starts. We will be recording this session so that you can watch later on, but that you can also share. So please share widely. And we will make sure to have time at the end. We have a whole 30 minutes that we have slotted for audience participation and Q&A. So please enter your questions in that chat box throughout the entire time, and we will make sure to get to as many questions as possible. So I'd like to introduce my colleague, Tyrone, from the Ulster County Commission on Human Rights. Ty?
Hey, thank you, Nadia. Appreciate it. Hi, my name is Tyrone Wilson. I am the Human Rights Commissioner for Ulster County. I am extremely excited that we continue the collaboration with Dutchess and Orange County. This is such a wonderful thing to be in collaboration and partnership, and also showing this kind of unity with our departments and addressing human rights. I just want to say this is our, first of 2021 web series, and we are looking to have so much more. And I hope that you all continue to join us and be a part of, this family. I would like to call this family, and be a part of this and enjoy our wonderful presentations and so many wonderful people who comes forth to be on this panel to, share some wonderful knowledge, and also giving you the opportunity to ask questions. And I just ask that, this web series, that we don't let it just stay here. Let's take it in, and let's continue to collaborate and try to make all our communities a better and safe place. So with that being said, I would like to introduce to you my other colleague from Dutchess County, Ms. Jody Miller.
Thanks, Ty, and welcome everybody. I'm Jody Miller with the Dutchess County Commission on Human Rights. And I also want to recognize one of our work group members and commission member, Jen Drake, who's been an instrumental part of our working group. So I want to thank Jen for all of her work. And I echo what my colleagues have said. We're really thrilled with this collaboration and to bring topics to our communities that are affecting all of us in the Hudson Valley and beyond. The Dutchess County Commission on Human Rights this year, one of our priorities is COVID inequity and impact. So although our speakers today are going to talk more broadly, they're also going to talk about how COVID has impacted the BIPOC community. So without further ado, I'd like to welcome you and just read a little bit about the amazing backgrounds and experience that our presenters here today bring. First, Megan Deichler is the Executive Director of the Catskill Hudson Area Health Education Center, an organization focused on supporting the health care workforce through providing educational opportunities for youth, students, and existing health professionals. CHAHEC, I hope I'm saying that right, Megan, acronym, covers an 11-county catchment area in the Hudson Valley, which includes Dutchess County, and has worked on career exploration programs with youth in the city of Poughkeepsie. A goal of CHAHEC is to bring more diversity to the health workforce and encourage historically underrepresented students to consider careers in healthcare. Prior to joining this organization, Megan spent years working in a variety of areas of public health, including population health research and health philanthropy. Megan spent several years working with the philanthropic organization, the Leona M. and Harry B. Helmsley Charitable Trust. While at Helmsley, Megan helped lead the development of a number of grant-making strategies to improve access to healthcare and essential medicines in low-resource settings. Earlier in her career, Megan worked at New York University on population health research on topics including Lyme disease and HIV/AIDS incidents among vulnerable youth in New York City. She holds a Master of Public Health degree in International and Community Health from NYU and a bachelor's degree from Manhattanville College. She's on the board of the Dutchess Orange Region United Way and a member of its Community Impact Committee, and she lives in the city of Poughkeepsie with her husband and their dog. Megan, welcome. Next, we have Giovanna Rogow, MBA, who is the Executive Director of the Maternal Infant Services Network of Orange, Sullivan, and Ulster Counties, MISN, a perinatal network established in 1990 to improve birth outcomes and reduce ethnic and racial disparities leading to infant mortality, preterm birth, and low-weight babies. Giovanna believes strongly that an investment in girls and women makes communities stronger, benefiting all within that community. In her spare time, Giovanna enjoys practicing yoga, sewing, hiking, spending time with her husband and family, including 3 grandchildren and 1 great-grandson. So welcome, Giovanna. And Edna Muhammad, LCSW CCN. Edna is a licensed clinical social worker and certified case manager. Edna Shanks Muhammad is a clinician who has worked for over 18 years in health-related and behavioral health care settings, providing direct and indirect therapeutic services, crisis intervention, collaborative care, case management, advocacy support to individuals, families, and the community. Edna is currently a clinical supervisor for CFTSS program at Astor Services for Children and Families. Outside of Astor, she is a private practice therapist, educator, and CEO owner of Square of Wellness, LLC. Welcome, Edna. And without further ado, we'll begin our presentation and Megan will start. Thank you, Megan.
All right. Can everyone see my screen? Yes?
Yes, we can.
Great. Well, first of all, I want to thank the organizers for inviting me to speak today. This is a very broad topic, and I had a little bit of trouble sort of deciding what areas to focus on, but I think, I'll start off by talking a little bit about social determinants of health and how they impact specifically Black, Indigenous, people of color. And I'll use the phrase people of color just to keep things a little bit easier for me. And so, I can't, let me see. There we go. So Jody did a great job of introducing myself and the organization that I work for. As Jody mentioned, I work for the Catskill Hudson Area Health Education Center, which we call CHAHEC for short. And we cover an 11 county region, which includes Dutchess, Ulster, and Orange County. Our office is based in Ulster County and Highland. But as Jody mentioned, I live in the city of Poughkeepsie, and our goal is to improve the health workforce, specifically within medically underserved communities. And so we do that by working with students, both high school and students in health career track programs, so medical students, nursing students, et cetera, to introduce them to the needs of medically underserved communities. And then we also work with existing health professionals to do continuing education trainings around relevant topics, such as social determinants of health, cultural competency, and things like that. So that is us in a nutshell. So I first wanted to give a definition of what is health equity, because throughout this presentation, what we're really getting at is the fact that certain communities, and in this case, like I said, I'm focusing on communities of color, do not have the same health outcomes as other communities. And so health equity is achieved when every person has equal opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstances. And so health equity, obviously it impacts everyone, Black, white, and really what it comes down to is it's an issue of poverty and other social issues, but unfortunately it disproportionately impacts communities of color. And so that's what I'll be focusing on today. And so just getting into it, so social determinants of health. When it comes to health, obviously there are some things that are out of our control, such as genetics, but a large majority of things that do impact our health are things that we can control and things that are preventable. And so it's estimated that when it comes to things that we can control, about 80 to 90% of those things that impact our health are what we call social determinants of health. The other 10 to 20% is the actual medical services and the actual healthcare that we receive. But an overwhelming majority of what impacts our health are social determinants. And again, things that can either determine whether we have good health or bad health. And so this is a list of different examples of what impacts our health. And so, we start off with economic stability. Again, as I mentioned earlier, poverty is a huge determinant of health. And, it impacts not only the person's, paycheck every week, but it also impacts their ability to be in safe, healthy housing, transportation, live in a safe neighborhood, have access to the highest quality education, nutritious food, et cetera, et cetera. It goes on and on. So economic stability is definitely a key determinant of health. The next, moving on, we can look at how housing, transportation, safety, ability to exercise outdoors and access parks and walkability, how these things also impact health. If you live in an area where it's not safe to walk around outside, or you don't feel safe, then you're going to have less opportunity to be active and exercise. And of course, we know that those impact health. And in terms of zip code and geography, there's been a number of studies that show your zip code, we can predict your health based off of your zip code. There was a famous study that was published a few years ago in New York City looking at the subway system, the number 6 line, and within 3 stops from the Upper East Side to Harlem, which is 2 different zip codes a couple miles away from one another, there was a 15-year lifespan gap, life expectancy gap. And so again, these are disparities that we're seeing when it comes to individuals' healthcare or health. And And then finally, as I mentioned, access to high quality education, food, social and community support, interaction, and then finally access to a health system that is supportive of the community. And so healthcare providers that come from the community, that look like the community, that understand the culture of the community. All of these things impact health. And as I'm sure you all are aware, given our history in the United States and a lot of how our society is set up under structures of systemic and structural racism, unfortunately, people of color are more likely to live in poverty, more likely to have housing issues, difficulty accessing the best quality primary and secondary education, and the list goes on. And so these social determinants are a big part of why we see such huge disparities in lifespan, in morbidity and other health outcomes between people of color and non-people of color. So as I mentioned, we have these huge gaps when it comes to the health of, and in this case, what this graph is showing is Black Americans versus white Americans. And a lot of these things, again, you can trace it back to the structural racism that we have in this country and why there are disadvantages for certain communities. Overall, Black people have lived 4 years less than white people in the United States. People of color are more likely to have chronic conditions such as diabetes, heart disease. The list goes on. And just in looking at these graphs, you can see that there are wide disparities, and particularly among young people when it comes to these different social issues. So I wanted to give an example of how something that you wouldn't necessarily think impacts health actually impacts health. And so this is a map of Richmond, Virginia, and this is an example of how housing it has impacted health for many generations. So I'm sure many of you have heard about redlining policies that were enacted in the 1930s by the federal government, where basically the housing authority mapped out different communities, cities, and towns throughout the United States, and was able to, it's called redlining because they drew red lines around communities that were predominantly made up of people of color. And what they did with these maps was they were able to deny mortgages to individuals wanting to move into these communities that were predominantly inhabited by people of color. And so if you wanted to live in one of these communities, you could not get a mortgage, you could not take advantage of federal programs such as FHA loans. After World War II, a lot of veterans coming back home and taking advantage of the different housing benefits, mortgage benefits for veterans, could not live in these neighborhoods and could not get mortgages. And as a result, the people who lived in these communities, the people of color, also could not get mortgages, could not refinance. And so although redlining was abolished in 1968, the impact is still, you can still see it here. This picture shows an example of two different neighborhoods. One that's in sort of a green neighborhood that was classified as the least diverse, mostly white neighborhood, and then another neighborhood that was within this redlining districting. And you can see that a generation later, you still have great disparities when it comes to poverty, when it comes to diabetes, obesity, high blood pressure. And again, these policies and our history have had lasting impacts on the health of our communities. And that's why we still, to this day, even though redlining is not legal, we still have, we're still facing a lot of these impacts. And so anyway, this is again an example of how something like housing that one wouldn't typically think about when it comes to health, how it has impacted health. So I wanted to talk a little bit about something that is our everyday reality, which is COVID-19, and discuss a little bit about the racial disparities that we've seen from those who have been infected, hospitalized, and who have unfortunately died from COVID-19. And so this was a quote that was actually part of an op-ed in the New York Times yesterday that said, while Black and Latino people make up only 13 and 18% of the US population, as of November, they accounted for more than 50% of the country's COVID-19 hospitalizations. Native Americans have been nearly twice as likely as white people to die from COVID-19. And so again, when we're thinking about why is this the case, why are people of color disproportionately more likely to have COVID-19 and complications of COVID-19, we can look back at the social determinants and the fact that people of color are more likely to have low-wage jobs without the flexibility and ability to work from home. A lot of people of color were on the front lines, working in both healthcare and just in essential work in general, and therefore being at a greater risk of being exposed to COVID-19. Housing, the fact that people of color are more likely to live with multiple generations of family members because, again, this history that prevented families from owning homes and creating generational wealth. All of these things combined, transportation, all of these things combined have put people of color at a greater risk for developing COVID-19. So now we have a vaccine. And so one would think that, again, a condition that has disproportionately affected certain communities, that there would be more of a focus on those communities when it comes to preventing this illness and treating this illness. This graph here shows the yellow dot is the Black general population in each state. So for example, if you look at the bottom in Mississippi, about roughly 38% of the state is Black. The green dot is the share of the Black population that has been vaccinated. So ideally, the dots would be on top of each other, because you would think if 38% of the population in Mississippi is Black, 38% of the share of vaccines should be going to Black people. And in fact, the fact that people of color have been disproportionately impacted by COVID, it should probably be even more than that. But, we're seeing a different picture. 80% of vaccinations that have happened in the United States have been received by white people. And, of course, this is all taking into consideration many factors, including vaccine hesitancy and things like that. But there's a lot of research coming out that's showing that although, we all believe that there would be more hesitancy among communities of color, it's actually pretty equal between white and non-white communities in terms of vaccine hesitancy. And the reason we're seeing a lot of these gaps throughout different states is that for individuals who, again, are living in poverty, may not have the flexibility to leave work early, to travel, to go find a vaccine. It's resulted in this sort of situation where we see that although this condition has disproportionately impacted certain communities, unfortunately, the vaccine is not reaching them. So after all of that, that's been presented, there are solutions to this issue. And so this is what in the public health community is called sort of the triple aim diagram for addressing social determinants of health. And so the first tier is implement health in all policies. So let's not only focus on healthcare when we're thinking about health. Let's look at housing. Let's look at nutrition, income inequality. Let's implement health into all these policies. Expand our understanding of health. We need to collect more data on these disparities and these gaps that we see between different races and ethnicities. And then finally, strengthen a community's capacity to, again, address a lot of these issues that are ultimately social issues. We need to invest in social programs in communities where we see the greatest disparities in terms of social determinants of health. And then finally, a lot of local governments across the United States, including a lot of professional organizations such as the American Academy of Family Physicians, have actually declared racism a public health crisis. And there's been a lot of advocacy going on right now around pressuring the CDC and the federal government to declare racism a public health crisis. And the reason why is because declaring a public health crisis will require that more resources be put towards understanding these issues and understanding solutions to close these gaps. And then finally, I just wanted to leave with this picture, which I'm sure many of you have seen time and time again during these sorts of talks. But this was the first time that I had seen this picture with justice as another option. So obviously equality is the assumption that everyone gets the same supports and it's equal treatment. But as you can see, the one person at the end still can't see the game. Equity is giving support where support is needed to produce equity. And then finally, justice, which is what I like in particular, is that everyone can see the game because we've removed the systemic barriers that were blocking the game. And so obviously it took generations to build these barriers, and these changes will not happen overnight. But I think that is ultimately the aim that we should be going for in terms of addressing this issue where we're seeing great disparities in health amongst our communities. And so again, I just want to say thank you. If anyone has any questions, I've left my email address there. And yes, thank you.
Thank you so much, Megan. We will be addressing questions to all of our presenters today at the end of our presentations. So please enter them into the chat box. Next, I'd like to introduce and welcome to the space, Giovanna. You're still on mute, Giovanna.
Can everyone hear me now? Can you hear me?
Yes.
And can you see my screen?
Yes.
Okay. Hi, everyone. I'm Giovanna, and I'm going to be talking this afternoon about the disparities in maternal health in the Black community. So I have a few questions here that I put on this slide. And we'll go quickly through this. Did you know that Black women are more likely to experience a preventable maternal death compared to white women? And that 22% of Black women report discrimination when going to the doctor or the clinic. And did you know that between 2002 and 2016, maternal mortality in New York State increased by 27%? And did you also know that Black women die at triple the rate as white women giving birth, regardless of education, income, or any other socioeconomic factors? According to the World Health Organization, Black women in the United States die at the same rate as pregnant women in Afghanistan and Uzbekistan. I wanted to here define the definition of what I'm talking about in relation to maternal mortality. What does that mean and why it's important, so that we are all working off of the same definition. Maternal mortality refers to the deaths due to complications from pregnancy or childbirth. So the World Health Organization defines maternal mortality as the death of a woman while pregnant or within 42 days of that pregnancy term. The CDC extends that period to 1 year from the end of the pregnancy. And as an aside, a factoid here, the US maternal mortality rate has more than doubled from 10.3% per 100,000 live births in 1991 to 23.8% in 2014. So basically, what does that mean? That means that there's a death every 2 or 3 minutes. Black women in the United States have the greatest risk of dying from pregnancy complications among 11 high-income countries. And why is this important? It's important for several reasons. And I love talking about this. I've shown the movie Death by Delivery. I don't know how many of you have seen that movie. It's a great documentary that speaks about maternal mortality. And every time that I've shown that movie, the audience has been absolutely shocked when they hear the percentages of Black women dying. It's important because of these medical causes that you see on these slides. And also, Megan talked a little bit about social determinants of health. Social determinants of health also include things such as weathering. And you may be asking yourself, what is weathering? Weathering is a Black woman's, is that a Black woman's body ages faster than a white woman's body. And they age faster due to exposure to chronic stress. And some of that chronic stress, because we can talk about a lot of things, but some of that chronic stress is caused by microaggressions and systemic racism that is experienced on a daily basis. And then that becomes cumulative in your body. The other thing that I consider to be really an important part of social determinant of health is health insurance policies that are not always workable and contribute to inequities that impact access to primary care physicians. And I will say that over the last 6 months in New York State, we've had over 700,000 enrollees in Medicaid. Medicaid also pays up to 50% of births. So a global cap forces underfunding in critical programs like that. Under traditional Medicaid program, federal law requires that state provide pregnant women who have family incomes of up to 138% of the federal poverty line with pregnancy-related services. So I mentioned this because this is really important. What is 138% of the federal poverty line? If you're a family of one, that's $12,880. If you're a family of two, that is, I meant to say 17,000, not 12,000. If you're a family of two, 138% of the federal guidelines is $24,000 a year that your family is earning. If you're a family of three, it's $30,000. If you live in the Hudson Valley, you know that it takes a lot more than that to make a living in the Hudson Valley. I also talk about transportation, which Megan also talked about, and housing. Access to transportation is really, really important because sometimes women to get OBGYN care have to travel a long ways, especially if you're in a rural community. In the movie that I just mentioned, there were moms that were pregnant in Georgia that had to travel 100 miles round trip for their pregnancy appointments, for their WellCare appointments. And we all know what the situation is related to transportation in many of the counties that are represented here in the Hudson Valley. For us at MISN, we had a client that lives in Sullivan County. Her baby, when it was born, got transferred to Westchester Medical Center in Westchester County. The mom had no transportation to get there. Her baby was born premature. And so you figure it out how, was the mom gonna go see her baby every day, or the trauma that it caused by not being able to see her baby because her baby was almost 75, 80 miles away. Housing is also here. Did you know that in general, if you don't have a home, your life expectancy is anywhere from 10, 20, 25, maybe even 30 years less than a person who is housed. When you think about a pregnant woman who is unhoused, that's particularly damaging. You're putting yourself at risk for low-term birth or early birth, preterm, and other horrific health consequences. That's why it's important. It's important because the rate at which Black women get C-sections in our country is way higher the rate that other women get C-sections in our country. As a matter of fact, the percentage that Black women get C-sections in our country is 35.4% compared to other races, which you see here in this slide. There was recently, I was looking things up. What are the current statistics? I want to know what the current statistics, and the CDC just published a study that stated that 42.4% of deaths among white women in comparison. I'm sorry, let me start again. So if you see here the second sentence, according to the CDC, per 100 live births, 14.1% of deaths percentage was for Asian Americans, 30.4% deaths among Indigenous women, but it was 42.4% percentage deaths among Black women, in comparison to 13% deaths among white women. The CDC in its report also went on to say that 1 in 10 Black women in America are uninsured in the United States. All people of color are in dire health conditions compared to their white counterparts. However, Black women fare the worst. And why is this important? It's really important because when I first learned of these, of the percentages, I was like, my God, you know, learning about systemic racism, bias, all of these percentages, is it really related to systemic racism? Is it really because of bias? The answer, of course, is yes. But in 2018, a commission was created by New York State to create these listening sessions because the statistics was staggering. They're staggering. And in 2019, New York State invested $8 million to combat maternal mortality. So they created these listening sessions. They went out throughout the entire state and they started asking women in the community, you know, what's been your experience related to you know, your pregnancy, going to the doctor? And here are some of the comments that women came back with. And this was consistent, whether it was women in Albany, women in the Bronx, women in the Hudson Valley. This was prevalent. They felt disrespected by providers. A lot of their questions weren't getting answered. They didn't receive enough information to make proper decisions. And they were feeling pressure to agree to certain medical procedures. Remember the statistic that I just showed about C-sections. And they felt a total lack of support during the prenatal and postpartum period. Was it implicit bias? So to be clear, I don't think that any doctor goes in, gets up in the morning and says, today I'm gonna mistreat my patients. But the way that sometimes we explain things to people that look like us may be very different than the way we explain things to people that don't look like us. And so implicit bias, one of the scary things about implicit bias, it's that it's unconscious, it's subtle. You don't realize when it's happening, or maybe you do. So it's a lot of staggering information. And I wanted to then go over some of the things and discuss with you, where do we go from here? What can we do individually, as a group? What can we advocate for? What can we speak to our representatives about? One of the important things related to maternal mortalities is to include midwifery and doulas in the delivery of care for women. I think that's important. And a lot of that care is not included by insurance company, and it is definitely not included by Medicaid services. So remember when I talked about the cap on Medicaid services, that's where this becomes important. In Manhattan and New York City, there is a pilot going on that would include doula services in the delivery of care. And that's something that we should continue to advocate for. My number 2 was increased range of birth options. So what if a woman doesn't want to go give birth in a hospital 50 miles away where her family may or may not be able to go visit? What if a woman wants to give birth at home? Increase the options for women. I think that all of us have a responsibility to educate ourselves about what the real numbers are saying, what the breakdown is, and be able to speak to that and be able to open ourselves up to the difficult conversations about systemic racism. On an individual basis, self-advocacy. Self-advocacy, when you're a person of color in general, especially though if you're a woman who is pregnant. Tell you, I went to the doctor not too long ago. They told me my cholesterol was high. The doctor called me at home, like at 6 o'clock in the evening, told me I'm going to put you on this medication. I said, what are the benefits of this medication over other medications? She said, it's the best. So I looked up the medication. One of the 5 side effects of the medication was memory loss. So my cholesterol would have came down, but my memory would have been impacted. In terms of quality of life, definitely not something that I'm looking at taking. And then maybe if she had looked at my record, she would have seen that I use an inhaler. And so it was contraindicated, the medication she was prescribing for people that used inhalers. So self-advocacy is important. Screening for risk factors, some of the risk factors that I talked about in my earlier slide, screening earlier. And of course, you got to have access to be able to be screened earlier. Increase medical professionals of color at every level. Have people that look like the communities that they're serving in be in those hospitals. Can't have hospitals where, I go in to have a baby and everyone that I'm speaking with does not look like me. That's scary. And then lastly, women-inspired neighborhood networks. So these are some of the things. Where do we go from here? I really encourage everyone to look up the documentary Death by Delivery. It's right on YouTube. It's eye-opening. Some of the things that here we at MISN do, we collaborate with a lot of partners. One of those partners is Mid-Hudson Chocolate Milk. We provide a baby cafe where moms can learn about breastfeeding, speak with other moms. We're doing that virtually now. We have a Black Maternal Health Coalition where anyone can join. And we meet monthly, the second Monday of every month. It's virtual. If you'd like more information, please put it in the chat and email us, and we can provide you the calling information for that. But we also have the community health worker program where women go into other women's houses and help them deal with the stresshood of giving birth, because it is stressful. It's stressful. And in these COVID, during this time, Megan talked a little bit about what's happening now during COVID. Well, imagine now if you're pregnant, you have other kids at home, how, and if you maybe lost your job or if you're working, how that feels, how it feels if you didn't have cable. Now you need to get cable in order to manage your kids' schoolwork. And if you didn't have it because of budgetary reasons, now you got it installed and you have it, how are you going to pay for it? So that's just really simplifying a situation of already chronic stress. So these are the things that I think, where do we go from here? The first thing is have the difficult discussions, self-advocacy, education, and then advocacy in the community. Why do we do what we do? I wanted to share this because we've been in the community for over 30 years. And I do believe that the family is the corner, it's the corner structure of communities, of our entire society. And mothers, none of us would be here without our mothers. So mothers are important. It's important to help them to honor them, and to, build a trusting relationship with those mothers so that they can thrive. Because really, maternal health is a human right. It is a human right. Thank you.
Thank you, Giovanna.
Thank you. Oh, I'm sorry. Thank you, Giovanna. Appreciate it. Next speaker coming forth will be Ms. Edna Muhammad.
Hello, everybody. Can everybody hear me? All right, so I'm just going to attempt to pull this open and then we'll get started here. All righty. Okay, so I am here today to talk from a perspective of the clinician, as well as give you some insight into what it may potentially be like to be a client who is a person of color who is attempting to be serviced in a certain way. So let's talk about it. If I can get this to work, it's not sliding. Okay. You all can't see the slide progressing, right? Now we can. Okay. So I am a believer that when we share stories about people's circumstances, we find a way to really understand what's happening. Hold on one second. I just need to move this out of my way because I can't see my slides. There we go. Okay, so this is what we're going to do. We're just going to set the stage for the dialogue, because we learn so much when we understand where people come from and what their circumstances are. So let's just give a little glimpse of what's happening, and then we're going to step into the lives of these particular clients so that we can see what their life may be like. And so as we start to talk about the topic of the connection, this is where we're going to begin. So we have a 70-year-old Black woman sharing a traumatic event from childhood surrounding a visit to see her aunt in an institution called Central Lunatic Asylum, the first facility designated for colored persons of the unsound mind. So just let your mind settle on that in terms of like what that could potentially look like as we go further. Then we have an 8-year-old Black child that is receiving trauma-centered therapy from a Black therapist in preparation for an adoption. This is the first time she's interacted with a Black woman outside of her mother, who is diagnosed with a mental illness, and since her removal and then being placed in foster care. And then our last case is a 30-year-old Black woman who's been denying herself treatment for her progressing anxiety and depression until she found a Black therapist. So let's just like step into their lives for just a second. I want to progress my slide. Okay, there we go. Okay, so in scenario one, think about the place that she's just talking about and describing. So at this particular place, Blacks were committed for a variety of reasons, mostly involuntary. So let's set your mind up in terms of that. It was a prison-like environment, overcrowding, there was restraints, physical abuse, and involuntary sterilization. So I know that the original Megan alluded to, potential things that stop the community from going forward with certain things. Well, this potentially is an example of what they're talking about, right? In this particular facility, over 1,500 individuals that were there were the product of involuntary sterilization. So let's hear her story as she tells it. So she's talking about riding in a car with her parents. And once they got to the facility, she was left to sit alone in a chair. And so all kinds of things were happening around her. She could smell things that didn't seem right. She could hear sounds. She could look around and see that the conditions were deplorable. So while she was sitting there, the only thing she kept thinking is, I hope they don't leave me here. Right? I don't want to be left here in this place. I'm not sure what's going on. So when her parents returned in the car ride back, and two, they never said a thing, never spoke a word about it. She had all these questions about what happened. And so the way she described it is her mother didn't talk about those things, that when you felt bad or you were having feelings that you couldn't control, you kept those things to yourself. You spoke to God. You went to church. And you read your Bible. So in listening to that particular story, what connections can be made to generational pain and trauma? Creating a space where addressing mental health issues is allowable. Think about choice, access to care, racism, and how race played a role in this space. Our second scenario, 8-year-old Black child preparing to be adopted by a white family, was receiving therapy due to trauma and to support the family with transition. So let's hear her story. So her mother was diagnosed with schizophrenia. And so in the midst of that, her mother was displaying paranoid behavior. And so she was traumatized in more than one way, right? She was removed from her mother's care and placed with a white family who was trying to provide a safe space for her, and in fact was transitioning to adoption for her. In the midst of that, they wanted her to have therapy. She was provided other therapists prior to that were not in her race, and she wasn't successful. So here comes this Black therapist who starts working with her, and what was happening in the space? This young girl started touching the therapist's hair. She started touching her skin. She started practicing speech patterns and her mannerisms. She started asking questions about, her Blackness and what does that mean? So what was happening in that space? What connections can be made to engagement, identification, race, and access? And our last scenario, 30-year-old Black female, successful career, only person of color in her role at her work. She has a child, she's in a relationship, she's a new caretaker for her mother who is ill, and she delayed seeking treatment. So what does her story say? So she started having increasing symptoms whenever she was asked to speak or participate at work. She was feeling extremely angry about her caretaker role, unsure of her ability to manage. There was a lot of shame attached to needing help or what does that mean for her. She started talking about in the space that she grew up in a household where she was told, you are strong, you don't reach out for help, you push through. There's no time for you to be sitting somewhere and talking about what's going on. Once she came up to the realization, I can't manage, she wanted to turn and look at someone who looked like her, but she had difficulty finding that person. So once she finally did, she went into the space. But what she said is that she waited. She waited until she found a person to connect with. So what connections can be made? Race, access to care, and generational pain. Now, I love this picture, and the picture, the word therapist can be interchangeable. It could be clinician or whomever. But when we look at this picture and we talk about the anatomy of a good therapist, what are we really talking about? And when you look at the picture, look at the things that pop out. Empathetic, connect with their clients, has mutual understanding of their clients, does a good job listening. So when a person of color reaches out and they want treatment or support, and they go in there and they don't have a person on the other end who they feel like has the ability to understand them or listen or connect, what happens? Where do they go in that space? And so wherever we are and whoever we are, if we're providing a service, we need to sit back and think about this. If I'm a non-person of color and I'm providing services to someone who is a person of color, where do I stand with this, right? Do I check in a way that makes sense? Am I able to be empathetic to what this person is saying to me? Does this person feel comfortable with me? Are they avoiding topics that they normally would talk about if I was a different person or a different therapist? So these are the things that we need to think about as we're serving our people of color community so that we know that when they're accessing services that we're giving them the best care that we can. So these are the things that are actually discussed in the space when someone is actually comfortable. So these are some of the things that people of color who have sought treatment actually say in the space when they have a person of color sitting across from them. Now, I'm not saying that when they're in a space and they're with someone who's not a person of color that they don't say these things, but these are the things that they said that they weren't able to say when they previously tried. So this is another reason why we have to create space so that if someone needs it, we give them access to what they need. So listen to what they had to say. As a leader of my family, how do I make space to address my mental health needs? So what is that person in essence saying? When we were talking about the statistics before about, leading a household and what the implications are, if we're down, what happens to the rest of the family? So these are things they think about before they seek treatment. Another person said, I've been told to pray about it and push through. So in essence, that's the only thing I can depend on. I wasn't supposed to go outside of that space to do that. I'm ashamed to admit I need help. I would be looked at as a weak person. Who set that up to say that a person who reaches out for support is weak? Where do those thoughts come from? Where did that person get that thought that I'm considered weak if I reach out for support and help? She told me I must have misheard that and shouldn't feel that way. So this is someone who said that when they went into a space and they met someone that did not look like them, when they tried to explain what was going on, they were told, you must have misheard. I'm sure that's not the way things happen. You really shouldn't feel that way. They didn't mean to do that to you. You need to let that go. So what does that do to a person who hears those type of messages? I feel so devalued. Why, when I speak up passionately about a subject, I am labeled aggressive or the angry Black woman. So this specific topic comes up a lot in terms of women who are working in different type of environments. They feel as though if they speak up in a meeting and they are passionate about a topic, that they're perceived in a certain way, and so they don't have space or freedom to talk. And that can become very like belittling, and also they start to feel anxious about being in settings where they have to talk. They worry about being judged. The other thing is I'm tired and frustrated with the images on TV. So they sit at home, they watch what's going on, they wonder if their family members are going to come safe home every night. And then where do they go with that information? Where do they feel safe and comfortable enough to share? So when we're talking about creating space, we need to make sure that we're taking these things into consideration. So when looking at how we're creating the opportunities for individuals, I look at it in terms of who, what, why, when, where, how, and how much. So let's like break that down. So who is the support that's available? So when I'm looking out there, who do I actually see? Do I have somebody? Is anybody around to help me? So what do I need to know or do first? So if I decide that I want to seek support, what do I need to know before I do that? Like, where do I find that information so I know how to move forward? Why do I need help now? I've been doing okay all this time. Why all of a sudden now it's becoming so difficult for me to make it through, right? For all the things that we talked about before, right? So when is the best time to seek support? Sometimes if we never tell others that now is the time, they don't go. It's like a similar thing when I work with individuals who are caregivers. We have to give them permission to care for themselves. Why? Because people need to understand that it's okay to seek support. So where is that support located? Where do I go? Can I go in my neighborhood? Can I go up the street? Do I have to go towns over? How many people actually know that telehealth services are alive and well and that I can do those type of things to move forward? So how do I actually access the support I need? So how do I get it? Like, is there a pamphlet somewhere that maybe I can read? Can I ask somebody? Like, how do I get it if there's something that I'm ready to do? Is there a website I have to go to? Is there a number that I call? Do I start with my insurance company? What do I do? So as you are setting up and putting things together about how people need to access what they need, these are things I want you to start to think about. And the last thing is, how much will it take? Like, how much time will it take? So there are a lot of individuals that are time driven, that they need to know, how long is it going to take for me to call this person and to actually get in? Think about the young woman who was reaching out for support. It took her 3 months on a waiting list before she got in to see a Black therapist, but she waited. And how much will it cost? So do I have insurance? Do I have the ability to pay for this? Do they have sliding scales? All that information needs to be readily available so that when I make the decision to step through the door, that I have that available to me. Now, some potential implications to consider when working with persons of color. So these are the things that are going on that are commonly not talked about and addressed unless the person feels safe and they feel like it's okay to talk about. So how is this person dealing or managing their life if challenged by race-related issues? So if I'm in a space and this is what's going on and really the source of my anxiety, but no one asks me how I'm dealing with race-related concerns or issues, then they didn't give me the space or the opportunity to kind of talk about that. So all things should be considered on the table. Does a person have trauma that's been passed on from generation to generation? So think about the 70-year-old woman who faced trauma as a child and what she did as she moved through her life. Did she talk about mental health in her family with her own children? Why did it take her so long to understand that she was holding on to something and she just needed someone to talk about? So if we look back into her family, what else has been going on? What has passed on from generation to generation? So is the person impacted by thoughts or feelings about exposure to racism, violence, microaggression comments at work? All these things are happening around us. And are we a part of the solution? Are we an ally? Are we the one who are actually making the comments at work that's making someone else feel uncomfortable? And so they feel judged, they feel as though they don't have a space. So we need to all look at ourselves and realize, where do I fall in that? How will society, family, friends view their decision to seek support outside of the family, outside the religious place of worship? I can't tell you how many times in the therapeutic space they have said, I really don't want to tell this family member because they're going to judge me. They told me if I pray about it, everything will be okay. I'm not going to feel comfortable sharing. So how lonely is that, to be in a position where you can't share with others what's happening and what's really going on with you? Now, those are the things to think about in terms of just a general overview. Remember, we talked about like patient perspective. We walked the path of a particular patient. We talked about our client. We talked about some of the things they may be thinking about, things that we need to think about when we're in this space. But then I want you to take a look at your own agency. And what I have done here is I've given some slides about the current agency that I work for, Aster. And I want you to take a look at your own personal agency report card so that you can reflect upon the status of your agency. Take a look and see where you are, see where you fall in terms of your efforts to move in a direction that makes sense. So what is the status of your agency in reference to how you're taking care of race, ethnicity? Now, there's other topics in general that talk about diversity and equity, but just for a moment, this is what we're going to focus on. And what are the demographics of the clients that you serve? Who are you supporting at your agency? Who are they? What is the racial makeup of the clinicians? And does that impact your clients in a positive or negative way? When Giovanna was talking about, what happens behind the scenes of maternal health care when people go in and don't see anybody that looks like them, that has an impact. So what are we doing from an agency perspective that's like leading the way and is talking about it? So when you look at your agency, is there an opportunity for training, engagement, recruitment, review of service delivery, realignment, mentoring, which is key, review of policies, checking in with clients that you serve, or checking in with clinicians who have questions about the space they are creating. So if they are creating a space where people of color are coming into that space, what are you doing to take care of the clinicians who serve them? So I want you to take a look and see what you find. So I'm going to show you a few slides that depicts like how you can view and look at statistics, trends, opportunities for growth. I want you to look at any service needs that pop up for you as you're looking at this. And then what are your observations from this statistical perspective? So look at Aster stats. So if you're looking at this, you're like, okay, so in Aster, this is only the clinicians, not the makeup of every employee that's a part of Aster, because we have over 800 employees that work for Aster with all the programs. But we, in terms of clinicians, and that's could be an outpatient clinic or other clinical service programs, we have a total of 178 clinicians. And out of the 178, look at the breakdown of the ethnic background of the clinicians. So by looking at this, what do you notice? Look at how many individuals that we have of Asian descent, how many individuals we have of Black descent, Hispanic, Native American, like Native Hawaiian, 2 or more races where they consider themselves mixed or biracial and wanted to include more than one. But look at the number of white clinicians that we have in our agency, 110. So when you look at that, you think, well, wait a minute, we have all of this makeup. What does that say in terms of who we're serving? So let's take a look. So now when we look at, can't really see. Now, when we look at the statistics regarding like who we actually serve, I broke it down in terms of client data by race and gender. Now look at this in terms of like clients. For Hispanic, which is our largest population that we serve, 28.74% of our population that we serve is Hispanic. white 28.17%. This is interesting. When I asked them to pull the statistics, when they pulled it, this information is pulled from the system. So that means that the clinician is going in and entering the data. And when they enter the data for the statistics, they chose to leave the question blank. What does that mean? I don't know, but I have to look back and take that back and say, what does this mean? Did we not ask the question? Do we feel uncomfortable putting it in? Do we not know? But blank, 17.81%, which accounts for what part of the population? And then Black counts for 16.36% of the clients. Just interesting, right? When we look at the data, what does it say? So I went one step further and broke it down in terms of like client demographics, right? Because it's one thing for us to look at the clinicians we serve, and then we move forward to talking about it in a different way. So when we break it down and apart, client demographics by city, and then we see where our services are kind of allocated and where they're spread out in terms of who we actually serve. So 45% of our population is in the Bronx, right? So that means the other part is like in the Dutchess County area. So then when you look back at the clinicians, does it make sense? Are we excluding certain populations? Do they not come because they don't see anyone that looks like them? All those things matter when we're looking at the statistics. Now, in ASTR's efforts, just like everyone has to look at their own agency and say, what are we doing about what we found and what the data means to us? So for ASTR, our response has been to formulate the DEI committee, diversity, equity, and inclusion. And although it doesn't just include race, it includes all aspects of what that means, but this is what we're focused on. We pulled together a committee. It's comprised of agency representatives across disciplines, racial and ethnic makeup, and gender. We're focused on staff development and skill building for the agencies, so we're developing curriculum around that. We're focused on diversity and equity and hiring, so we're looking at how we bring people in, how do we keep people on board. We're focused on education and awareness, so how do we bring new education topics, how do we make people aware of everything that's going on. And then we're focused on creating space for discussion and processing. We literally have processing groups where individuals can come and process how they feel about this particular topic. So I hope that I have shared something today that made you think, that made you pause, that made you think about how we need to be inclusive of our practices and policies and how we engage with individuals of color. So if anyone needs to reach me, that is how you do it. So this is my email addresses, so for ASTR and then outside. So thank you so much for allowing me to spend some time with you. So if I can figure out how to stop share, I can go back. So thank you.
Wonderful, thank you.
So much.
Okay.
Sorry, Jody, I was getting on, but my mute was all off. Thank you so much to all of our presenters. I hope you got a lot of really wonderful information. I know I always learn something new when I hear these incredible presenters. So we have some time now for audience Q&A. So we want to encourage any questions that you may have. Please enter them into the chat box. We do have one question that I'm going to scroll up here. This question says, I would like to hear about how universal healthcare programs like the proposed New York Health Act could impact BIPOC communities in terms of their overall health and well-being and reversing some of the effects of systemic racism. So I will repeat that, and this can be open to all of the presenters. If you can, share your opinion, share what your thoughts are. So I would like to hear about how universal healthcare programs, like the proposed New York Health Act, could impact BIPOC communities in terms of overall health and well-being and reverse some of the effects of systemic racism. Would anybody like to tackle that one? Megan, do I see you are off mute?
Yeah, I can start. So yes, I mean, universal health coverage would definitely impact a lot of these issues. And it's interesting because, as many of you probably already know, we're one of the only countries, despite being the richest country in the world, we're one of the only industrialized countries that does not offer universal health coverage. And within a universal health coverage program, there would be a strong emphasis on prevention and implementing programs that address a lot of these social determinants of health. And you see that across the world, really. There's actually, as Jody had mentioned during my intro, I did do some work prior to this role working in international health. And there is a goal that by 2030, every person on the planet will be covered by universal health coverage. It's called UHC 2030. And so many countries, low, middle income countries, are on track to achieve this goal. But here in the United States, again, I mean, we can afford to do it. In fact, it would save us a lot of money to have a universal health coverage program, because we would prevent a lot of these conditions that do end up being costly and cause people to lose productivity and unfortunately have premature death. And so anyway, all of that is to say that yes, universal health coverage, a program like what's currently being considered at the state level, would definitely impact a lot of these issues and close the gaps, because access to healthcare is a huge issue when it comes to looking at who has access and who doesn't.
Awesome. Thank you, Megan. Any of the other panelists want to touch on that question? Are we good?
I feel the same, especially if it covers prevention programs like chiropractic care, homeopathy, and mental health care. There's so many aspects of mental health that are not covered in current insurance plans. You go to the hospital for 3 days, you get released. After 3 days, you're supposed to be stable, and then you have to find a therapist. Then you have to find how you're going to fill those prescriptions, and your healthcare insurance may or may not cover it. And so universal healthcare, especially if it covers prevention, doulas, midwifery, and some of these other programs, would be a benefit.
Yeah, I also agree. I would say that when we were talking about what stops someone from following through with the process, remember that last thing is, how much will it cost? How will this make it work? How will I get, all those questions about how we get what we need. It could potentially be another roadblock if we don't figure out a way to get them there for that, to close the gap.
Awesome. Thank you for that. So we still have time, so we're encouraging everybody to put your questions in the chat. So we can ask the panelists these questions. I see a lot of comments, but not a lot of questions. So we can start tapping in some of the questions in the chat. We would love to share this with the panelists. But we do have one here from Hannah. What about women from Central and South America? I think that's her email. What is their access to healthcare? I don't know if we can. Anybody want to tap onto that question? Basically, what about the women in Central or South Africa? What is their access to healthcare? If any of you know anything about that.
So MISN has the Navigator program, and we sign up community members for healthcare. If an undocumented person comes here, they are covered. We can register them for healthcare the first year that they're here for emergency Medicaid. And then when they have a baby, the baby is also covered. So after that, you can call MISN, and you can call us at 845-561-3575 to get additional information, or email me to get additional information. But there are options to healthcare.
Great. So another question. What is being done to diversify the workforce and bring more people of color into healthcare?
I can answer that question. So my organization is one of 9 centers throughout New York State, and actually there are 300 centers, area health education centers throughout the country. We're a program that's funded primarily 50% by the federal government, 50% by the state government. And part of our mission is to improve the health workforce. And how do we do that? We do that through diversifying the health workforce. And so some of the programs that we do start young with students who are in high school, middle school, particularly within communities where there is an underrepresentation of healthcare workers that represent the population. And so we work with these students to introduce them to what careers are out there, encourage them to consider careers in healthcare, and also show them examples of individuals who look like them who are in those positions in healthcare. And then we also work with students who are already in medical school, nursing school, PA, et cetera, to again, introduce them to what are the needs in these communities that need health workers the most, and encourage them to come back and work in their communities where they were raised and where there is the most need.
Thank you, Megan.
Another question that we have from the chat, and Giovanna, it sounds like this one is for you. Is there any data comparing the rates of people of color maternal mortality in the US versus other countries?
There is data on that. I don't have it off the top of my head, but there's plenty of data. And the US is pretty low on the totem pole related to data all across the board, related to healthcare, maternal mortality on all levels. And I just posted my email on the chat. And if you send me your email, send me an email, I can forward you some of that data. I saw a comment on the chat about adultification of girls of color, and I wanted to speak to that. And adultification of girls of color is when Black girls are viewed as being either less innocent or adult-like, more so than their white counterparts. And we've seen that play out in the news when we saw a policeman basically throw a girl down on the ground, and in Texas, I think it was, and here in New York State, we recently saw a little girl, I think she was about 8 years old, between 8 and 11, in handcuffs in a police car because the police had arrested her. And so I just wanted to comment on this and bring it back to what the media shows and our responsibility as the community. We need to have and be open to having the challenging conversations, the difficult conversations, talking about differences and what separates us. Because until in the community we're able to talk about it, nothing's going to happen on a higher scale. We are the ones that are creating policy. We create policy when we become involved in part of the system. And I think I said this on another call. One person talks to another person, now there are two of you. And when you talk to the third person, now there are three of us. And so this is really important because this is something that it doesn't, I don't know how many of you watched the interview with Prince Harry and Meghan Markle. And so it doesn't matter the level of how much money you make or how educated you are, right? You could be part of the royal family and here you're experiencing outright racism. So, you know, I always say it's up to us to start talking about it, talk about it. And if you're an executive director out there, then it's up to us to really recruit boards that reflect the communities that we're in, to recruit staff that reflect the clients that we're seeing. And we are the ones that are in those positions to make that stuff happen, right? And so I just wanted to be for real, because if we're waiting for this to happen somewhere else out there, we are the out there that can make it happen. And these are valuable conversations, but they bring more value when they're followed up by action. at whatever level we're in.
Mhm. Thank you, Giovanna. That was very powerful. Okay. Ty, next question.
Oh, I'm sorry, I'm looking for one now, but this kind of, I want to go back to it because this is kind of I was trying to find it. And this was going back to Giovanni, when you was first speaking on the immigration part, undocumented individuals who come in to the country for services. And I know one of the questions, I can't find it now, but somebody was asking, does those services also contribute to having services for mental health?
I'm not sure, but you can contact, if you send me an email, I will put you in contact with my Navigator program manager, Joan Ruiz, and she would be able to help and answer the specific questions.
Okay.
Thank you so much. So I just want to ask this final question, and maybe this will close us out in a nice way, so that if everyone can answer, that would be really great. So the question is, what can I do as an individual to make a difference? Giovanna, you talked about executive directors and diversifying and making sure that the staff, right? And you talked also about making sure that staff represent and reflect our clients. I'm wondering if all of you can just kind of chime in for a quick minute to close us out. What can folks on the call do? Maybe they're not executive directors and they don't have any power over hiring decisions, but what can they do to help with disparities in the BIPOC community?
I think the first thing you did was be on this call. and that is, and you heard a lot of data and you heard a lot of facts. The second thing is go out and learn a little bit more about it. And the third thing is talk to someone about it, talk to another person about it, and then get involved, because we all lead or collaborate with someone else, right? And so get involved, and we all work, right? We're all in the workspace, and we've experienced this at some level. And so when you see something that that really is a microaggression, perhaps you stop and and speak to it, and speak to it, call attention to it.
Okay, I'll go next. I guess I just want to remind everybody that that if you're truly validating, people in the space, really pay attention to what that looks like, to make sure that that the efforts that you're doing is really making a difference to the person you're trying to do that with. Because if you're not taking into consideration their experience and what their life is like, then it could be a lost moment and a lost opportunity, regardless of who you are. The other thing is that, I showed the last slide in terms of trends because looking at the data in a specific way gives us information about what we're doing and whether we need to think about how we service our community and whether we're really hitting the mark. So I'm just going to encourage you to start there. Even if you don't know what to do about the data that you find, knowledge is power. And so when you know what's happening, you can make different decisions. So thank you.
I just put my email in the chat, but I guess the only other thing that I would add is, and this is going back to policy, but as you learn and learn about these issues, I think that advocating for changes, talking to your local legislators, pushing for things that you think could make a difference when it comes to these issues, like we were talking about earlier, the New York State Health Act that's currently up for consideration. I think at the end of the day, advocacy and pushing for policy change can make a huge difference for these issues.
So on behalf of all three of our commissions, I want to thank Edna, Megan, and Giovanna for joining us today and sharing very, very powerful and important information that we all need to hear. And I would just, in the spirit of what you've all just said to us, when we send this recording out or when it's up on our websites, one thing that you can do is share the recording of this webinar with people that you think can make a difference, or anyone you think can make a difference. So I would encourage you to share it with at least one person, if not more. So again, I want to thank you, all three of you, for joining us. This was so powerful. And thank everyone, all of our attendees today. We appreciate you taking the time. We appreciate you being here and joining us for this such an important topic that we need to be talking much more about. So thank you, and we'll be seeing you soon, hopefully in the next couple of months with our next topic. Stay tuned. We'll be sending out information about that. Thanks, everyone.
Thank you. Thank you so much for inviting us.
Hey, everyone.